Okay, so we're going to pick right up where we left off, just finishing up about tactile object perception, and then we're going to get into pain. So when we look at some of the things that we talked about, we're going to kind of relate this back to vision, where we talked about those surround cells. So the inhibitory surround cells and excitatory center cells, and vice versa. We had excitatory surround and inhibitory center. If you guys remember those in vision, so we would have this cell here with this in the middle, and this would be, for example, excitatory in the middle, and then surrounded by an inhibitory surround. And so these are very helpful receptor fields because they allow us to be able to have specialized receptor areas that respond to particular features, right? So orientations, particular direction, if something is sweeping across this field versus, a particular orientation, a vertical orientation or a horizontal orientation or an oblique orientation. So just like we had these in vision, we have these also for touch. So these particular mechanoreceptors that we have, these are important for helping us figure out different features of the object that we're touching, and of course, the further upstream we go in this process of cortex, of cortices that are corresponding to those touch areas, for example, in the somatosensory cortex, we see that these particular cells are responding to particular orientations and directions of movement in terms of touching that we see the same way in vision as in touch. And so these particular studies were done with monkeys, looking at the thalamus and these particular center surround receptive fields, like here, very similar to in vision, except in this case we see this on the forearm. And we do have evidence that these also exist in humans. So that's kind of it on tactile object perception. Now we're going to move into pain perception. And so the important part about pain is to understand that it's multimodal. That means that there are two components. We have a sensory component, and then we have an affective or emotional component. This makes pain very complicated. This is not something that is as easy as saying, you have a particular sensation and that leads to, ow, that hurts. There are different components to this, and when we look at the types of pain, we have three major types. We talk about inflammatory pain, which is caused by just sheer damage to tissue, damage to joints. Tumor cells that are invasive can cause pain because they are, depending on the tumor cell type, it can invade into tissue and or it can press on other tissue and cause pain and cause inflammation. And we're not going to talk too much about inflammatory pain or neuropathic pain. Neuropathic pain is where we see actual damage to the central nervous system, which can be caused by, for example, stroke in the brain. It can be caused by repetitive movements. For example, carpal tunnel syndrome is caused by repetitive wrist movements, where you are working at a desk and your wrists position is the same, and so doing that for years and years on end can cause carpal tunnel syndrome, which is specific damage to the central nervous system. We can also see spinal cord injury in some cases fall into this category or fall into this category as well. What we're going to focus on here is nociceptive pain, which is where we see signals that are impending damage to the skin, as in, this is going to hurt. So we see here, for example, heat, pressure, cold, chemicals. All of these signal pretty much impending doom, right? It's signaling that you're about to experience pain. And we need to make sure that in order for this to work properly, in order for us to be able to sense the impending pain and remove our our skin from it, right? We have to have a very, very careful threshold. And that threshold needs to be just enough to warn of damage, but not be affected by normal activity. So if you are, for example, picking up a ball, there's pressure that's being placed on your receptors in your skin. That needs to be enough for you to sense that you're touching it, holding it, feeling it. But then if you, for example, touch something that's hot, that threshold has to be different in order for you to be able to determine that that's really hot. I need to move my hand. Let's say you touch a stove. As soon as you place your hand on it, it needs to be very, very quick, and the threshold needs to be efficient enough to say, okay, warning, it's hot, remove before any further damage occurs. And so these nociceptive receptors here respond here. You can see there are different ones for each kind of type of stimulus. So here we have heat, chemical, pressure, and cold. And each one of those, essentially, the activation of each individual set of receptors is what is going to create that kind of sensation, right? So these particular nociceptors are responding to different kinds of stimulation specific to heat, chemical, pressure, or cold. And once that signal is sent here, right, it's going to travel through to the spinal cord, okay? And then it's going to then move up the pathway to the brain so that your brain can react to it, and then send the message down of, remove, for example, if you've touched something hot, or if there's too much pressure, to remove your skin from that source. Now, the early model of pain said that nociceptors are stimulated and then send signals to the brain, and it's a direct pathway. Okay, what's important here is that it's a direct pathway. It goes from A to B, and this is how we experience pain. But there's a lot of problems with that. First of all, pain can be affected by a person's mental state. That means that the threshold of which we experience pain can differ depending on our expectation. It can differ based off of how we are, how we're feeling. If we have a low mood, if we're excited, if we are stressed out, if we're traumatized, all of these can actually impact pain. So in cases, for example, where somebody is in a situation where they need to react very quickly because it's very dangerous, they might have a broken arm and they might not even realize it. But they're in such a traumatized, shocked state, or it's, to them it's going by so fast and they have other things on their mind, then they can actually not even feel it. Pain can occur when there's no stimulation on the skin. We can see this in phantom limbs, which we're going to get to in just a minute. We can also see it in cases of hypnosis. So we can actually, have people sort of experience pain when there is no stimulation. And then, we can do different kind of experiments with this. But ultimately, to experience pain with no stimulation is really debunking the direct pathway model, because according to the direct pathway model, you need direct stimulation in order to experience pain. Pain can be affected by a person's attention. If you're not paying attention to the pain, if you have your mind on something else, we can actually see where a person, their pain is reduced, or they are not experiencing it all. And we're going to get into another example of this in just a few minutes. So phantom limbs, this is a very interesting sort of concept phenomenon here. So we have no transmission from receptor to brain, because in phantom limb, in this particular example, we're going to use a person who does not, so this would be an example of a person whose arm was removed, or whether it was through surgery or there was an accident, and so their arm is removed. So all they have is this part right here, And phantom limb is where we would experience pain or sensation. Sometimes you can experience, like if it's the hand and you're missing, your hand, you can experience where your hand is in a fist, and it's very uncomfortable because you can't relax your fist. This part of your arm still has corresponding receptors in your brain, but those receptors are not receiving any more stimulation because the arm is gone. And so this is counter evidence to the direct pathway model, because there's no transmission from receptor to brain, but you're still feeling pain or discomfort, or whatever it may be. You're still getting the sensation of something, even though there are no direct receptors that are sending the signal. And of course, we know that in the brain there are still receiving areas for this area of the body, but those receiving areas, there's no way they're receiving stimulation from this part of the missing arm. And so this is debunking the direct pathway, and it's saying, hey, this is sort of disproving it. So when we look at, what is the next explanation, if it's not direct pathway, then maybe it's something called gate control. So the gate control model of pain essentially states that pain signals enter the spinal cord from the body and transmitted to the brain, but there are pathways that influence these signals that can open or close this gate that's in the spinal cord. And the cells in the dorsal horn of the spinal cord respond to activity from the nociceptors, activity from the mechanoreceptors, and what we refer to as central control. Central control has the ability to close the gates. These fibers can be influenced by things like expectation. It can also be affected by attention and distraction. And so any of these things can actually influence the center control, in the sense that it will close the gate. So therefore, if you close the gate, which you'll see here, if the gate closes, then there's going to be no transmission of cells, so therefore no pain is going to be experienced. So that's the central control's job, is to, control. It's like the gatekeeper, right? So it's going to help decide, or the bouncer, it's going to help decide who gets in and who doesn't. And the dorsal root here and the dorsal horn, this is where we see these particular cells being transmitted, signals being transmitted. Now, nociceptors, they're the ones where if you see increased activity with the nociceptors, you're then going to see that the gate will open, right? Which will translate to pain being perceived. Or the more activity of the nociceptors, the more pain you're going to experience, because the nociceptors are the ones that's going to send the signal to open the gate and experience the pain. The mechanoreceptors, these can actually close the gate depending on the signal that's being sent. So these nociceptors are trying to open the gate. These mechanoreceptor signals are trying to close the gate, and the central control, can come in and modify that process. So this gate control system can explain why some cases everything is set up for us to experience pain, but that process gets shut down. And so the idea is that there are some cases where, yes, we do experience stimulation. The nociceptors are sending the signal, the gate is open, pain is experienced, and it works directly. But there are plenty of examples where we see that it does not work that way, and you should experience pain, but the gate gets closed for whatever reason, the central control, mechanoreceptors, whatever it may be, and that in essence stops the process, and that does not get transmitted as actual pain. So let's talk about some of these examples where the gate gets closed. Okay, so expectation is one of those things where if you explain to a patient before surgery that that you're going to experience this kind of pain. What we find is that when you are realistic about these pain expectations, people respond to that. And it turns out that they experience less pain. They request less medication to manage that pain, and they also leave the hospital earlier, and they're more functional right after surgery. Placebos also have been shown to be effective in reducing pain, and as you very likely know at this point, placebos kind of fall into this idea of expectancy effects, where a placebo is like a sugar pill, or it's not doing what it's supposed to do in terms of being pain medication. A person expects I take a pill and then I won't have this pain, or it won't be as bad. And so you take the placebo and then you don't experience the pain, and then you're good to go. So we also see this in kids, for example. So you might see a kid fall over, scrape their knee, and then you say, oh, well, I have this magic cream, and that's going to make the pain go away. And it could be just Neosporin. It could be something that doesn't actually have any pain medication in it, but suddenly the kid goes, oh my goodness, I feel so much better. And so we see this happen in terms of expectancy effects. Also, we can see shifting attention. So what we've found that if you're not paying attention to the pain, we find that the pain is either reduced or it can actually go completely away. In cases where we have burn victims who have very large portions of their body burned, they can experience very, very large amounts of pain. And what we do is there are studies where doctors will do things like bring in virtual reality games and different kinds of things to get their mind off of the pain, because if you're just going to sit and think about the pain, then you're just going to concentrate on it and it's going to make it worse. Well, virtual reality, different games, just silly games, just something for them to kind of to keep their mind off of it. What they find is that it keeps their patient's attention on other stimuli instead of the pain, and it will actually reduce the amount of pain that they're experiencing, which is very important if you have a condition or if you're in the hospital after surgery or something where you see that the person's going to be in a lot of pain. We also see that shifting attention can help in terms of like hypnosis and other kinds of things. Concentrating on something else and getting your mind off of it can actually work to close the gate and lead to us experiencing reduced pain or actually making it go completely away. Now, the pain matrix, this is all the areas in the brain that are correspond to some pathway of pain. So that we have subcortical areas that are in this matrix. For example, the hypothalamus, the limbic system, and the thalamus. And remember, we talked about the thalamus being very important in terms of being a filter for a lot of different things, right? So it is involved in the pain process as well. We also have cortical areas that are part of the brain pain matrix, which is the S1 and the somatosensory cortex, that receiving area, the insula, and the anterior cingulate in the prefrontal cortices. So these are all very important in our ability to perceive pain. So these are all the areas that are involved, and these are involved in the pain pathway. So we know that, for example, the amygdala is important for the emotional part of pain. The thalamus is this sort of filter part. We see the prefrontal cortex, anterior cingulate cortex here being important for other aspects of pain. Hippocampus is important for memory, and we know that that's also involved with pain as well. Remember that pain is multimodal. We have the sensory and emotional experience. With the sensory component, looking at, for example, in the somatosensory S1 receiving cortex, we see somebody might describe a sensory pain as throbbing, hot, dull. It's what we experience, what we think of when we say pain. What does the pain feel like? Well, it's very hot. It throbs. It's a sharp pain. When we look at the affective or emotional component, remember this would be like, for example, through the amygdala, we're looking at people describing this pain as torturing, annoying, sickening. It's a different description. It's an emotional pain that can be experienced simultaneously with sensory pain, or it can kind of be more on the more emotional side compared to the physical side. Now, we know that there are neurotransmitters that are released in in the process of trying to reduce pain. And so endorphins are the neurotransmitters. They're endogenous, meaning that they're in our bodies. They're internal, right? As opposed to exogenous, right? So these endogenous endorphins are really, really important for our ability to manage our own pain. And this is something that we experience, and we hear a lot of cases of endorphins being released when you are, in a really traumatic event, and you're trying to get out, and you're not experiencing pain, and you feel that fight or flight response come in. Then we see, for example, that you have a high release of endorphins, you don't feel the pain, you have this sort of large boost in energy and strength. And we know that endorphins work to reduce that pain that you might feel. And we also know that naloxone, which is a medication, that it's a drug that you can use to actually block the receptor sites for endorphins. And when it blocks those receptor sites, the person is going to experience more pain. So naloxone also reduces the effectiveness of placebos, which means that it's likely something to do with our ability for placebos to be effective, it must have something to do with our endorphin release. We also know that when it comes to thresholds, so some people you might meet and they have a really high threshold for pain, and they say, oh, I could break my arm and it won't hurt that bad. And then other people have really low thresholds of pain and say, oh my goodness, all I need to do is get a small cut and I feel like my whole arm is going to fall off. And so we find that there is an association between the release of endorphins and pain threshold. And so this tells us that people who are releasing more endorphins likely have a higher pain threshold compared to those who have a low pain threshold. Now, naloxone is also one of those, it's a special drug because it's actually given to reverse the effects of heroin. So heroin and other opioids, morphine, for example, all of these different kinds of chemicals, what they do, or in the case of endorphins, for example, neurotransmitters, what they do is they bind to specific sites. Heroin and morphine will bind to endorphin sites. These are opiate sites. They will bind to these sites and give us that euphoria, the high, and the pain reduction. Naloxone very successfully blocks, it puts itself into these receptor sites and blocks the effects of heroin, endorphins, morphine, any kind of opioid. And so what happens is that EMT and so emergency technicians and emergency room doctors will have naloxone on in store, so that if somebody comes in with a heroin overdose, you can administer naloxone, actually reverse the heroin overdose if it's given in enough time, because it very successfully blocks those chemicals from binding. Now, when we don't not look at heroin or opioids specifically, we're looking at endorphins. Endorphins bind to these particular opiate sites, right? And then that leads to less pain. If we have a case where the person's experiencing pain and then we administered naloxone, it's going to block endorphins as well, because that's a type of, it's going to bind to that site. It can't do that when naloxone is administered. So what we find is that people will say, I'm experiencing more pain. And so that blocks the neurotransmitter from binding to that particular opiate site. So hopefully this is a, kind of an explanation of the pain side of things. If you have any questions, let me know. But that sums up chapter 14. And let me know if you have any questions, and have a great day.